Welcome friends. I am Dr. V.K. Chauhan, homeopathic physician, and we are revising here with homeopathic remedy Aethusa Cynapium. This is part 5, clinical correlation. The text is taken up from Allen's keynote and it is best suited to BHMS students of homeopathy. The first red line symptom given in Allen's keynote is especially for children during dentition in hot summer weather, children who cannot bear milk. This particular red line symptom has got following components. Component number 1 includes this is the medicine for children only. This is a constitutional characteristic of the client who requires this remedy. It is made clear at this point only by Dr. Allen. When it is required during the chronology of age when the child is growing, during dentition period, infantile period and childhood period. An environmental cause which excites the problem for which this remedy is required is in hot summer weather. And what kind of a child is this? This child is who cannot bear milk. This is the diathesis part. So, in this particular PQR1, he has encapsulated so much a big information. Let us try to elaborate this. The clinical correlation. As we know that this is a remedy which is especially suited for children. So these above features significantly and specifically point to the client characteristic who requires this remedy, and it is a children's remedy. During dentition, when the child is having incisors and lower incisors, they come. So child becomes vulnerable at the point of dentition. It points to the phase of first, yes, you can say primary teeth eruption, deciduous teeth. The mandibular incisor erupt at about 6 months of age, and last teeth to erupt is maxillary second molar around 14 months. So what are the high risk features during this particular phase? As the child is growing and having irritation in the gums because of teething taking place, it irritates the gums, and because of this, child is putting things, anything whatever he gets in his hands, or even he is going to put his fingers inside the mouth. And this is a very common source of GIT infection. The another component which we are dealing is when it is required in hot summer weather, as it acts as an exciting cause. And why the summer weather acts as an exciting cause? Because the waterborne infection is on rise during summer. The most important 5 waterborne diseases, they include cholera, typhoid, diarrhea, giardia, and hepatitis A. These are the very common problems you will find. And children are prone to suffer from gastritis, gastroenteritis, cholera, typhoid, giardia, and hepatitis A. Now, children who cannot bear milk is also given in PQR8. Eighth number of red line symptom also tells us, apart from the initial statement that children who cannot bear milk, it has been elaborated in the 8th red line symptom, and Ellen tells us intolerance of milk, cannot bear milk in any form. It is vomited in large curds as soon as taken, then followed by weakness and drowsiness, and comparison is from McCall. So this is a general aggravation because of food. Let us see clinical correlation. Children who cannot bear milk, This picture points to lactose intolerance in a very close sense. Lactose is a type of sugar that is actually found in the milk and other dairy products in different proportions. And lactose intolerance is found in some infants and they are unable to digest lactose. So it is a primary cause of lactose intolerance, which is very rare in children. However, people generally who we are going to see of lactose intolerance, they are having secondary lactose intolerance, which they later on acquire in life. Adults they acquire, but children primary is very limited or very few cases we have. However, lactose intolerance happens because of lack of enzyme that helps the body to absorb foods. This enzyme helps baby to digest milk, and that also includes breast milk. So symptoms which are going to point towards the lactose intolerance in infants is they have stomach upset, loose stools, they have colicky pain, they keep on crying very often, they are not gaining weight, runny green stool or diarrhea, irritability and uneasiness. So these are the common symptoms. What are the effects of lactose intolerance in babies? As we know that milk is very essential for healthy overall growth, babies suffering from lactose intolerance get deprived of the major source of energy, and when the child is deprived of energy, the energy is provided to him by the stored fat in the body, and the result is weight loss. So next red line symptom PQR2 is the great weakness. Children cannot stand, unable to hold up the head, and there is abrotinum which is having very similar features, prostration with sleepiness. So this is the state when the child develops because of lactose intolerance, and it is a state of exhaustion more or less. We'll examine it in its totality. It has got following components. Great weakness is a general state. Children cannot stand, unable to hold up the head. There is a lot of muscular weakness and wasting, and prostration with sleepiness. It indicates that there is a lack of energy and nervous exhaustion. Because of there can be not only protein calorie malnutrition but also micronutrients, vitamins and minerals, they are also lacking. We are going to have the clinical correlation. These features point to the undernutritional state. This occurs when the child is not getting proper nutrition such as proteins, calories, and micronutrients. The symptoms of protein energy malnutrition includes fatigue, low body temperature, diarrhea, reduced appetite, irritability, dry skin, hair loss, bruises, lack of emotions, difficulty in staying warm. So, in nutshell, we can see entire effect over the body includes the following features. The next PQR is 3, idiocy in children, incapacity to think, confused. This is the mental state the child has. Again, it has got following components. Idiocy in children tells us about the profound mental retardation. Incapacity to think tells us about low mental state, and confusion is lack of concentration. So we have here clinical correlation. These features point to various shades of mental retardation. What are the common causes of mental retardation? The most important one is iodine deficiency. Down syndrome is very important for us. Certain infections which take place during the pregnancy, like congenital cytomegalovirus, congenital rubella, congenital toxoplasmosis, encephalitis, meningitis, this is after birth. And mental causes, maternal cause includes like alcohol abuse during pregnancy. These are going to contribute towards mental retardation. Uh, According to the IQ classification, intelligence quotient is 100. A normal range of commonly people will have IQ which is 90 to 110. So the clinical features where we'll find level of mental retardation, approximate IQ score, and educational activities the child can perform, adaptive behavior which the child can learn, and level of support he requires. We'll examine the mental retardation in this particular light. So we have borderline mental retardation where IQ score is 70 to 79. These children are educable and they can adaptive behavior. They will learn to have the independent employment and level of support they will require. They will require not a very close support, but then in between they need to be seen whether they need any kind of a help or they are having some problem. The next level of mental retardation is a mild mental retardation, where we have the IQ score which may range from 50 to 70, and such children, they are educable to certain level and they are going to have very simple job and intermittent basis they require kind of a supervision. They cannot be left alone for their own decision making. Then there is a moderate type of level of mental retardation where we find IQ level is maybe up to 35 to 40 or 50 to 55. They are somewhat trainable children and they will require a trainable employment in a sheltered environment, and you have uh, to supervise them more than what you think in other cases of mental retardation. And then comes the severe mental retardation where we find the IQ level is about 20, 25 to 35, 40. These are trainable but dependent children's and trainable in some basic daily activities, and they require extensive support at least throughout the day, more or less. And then we have profound mental retardation. Here the IQ score is definitely below 20 and they require a custodial life support and they will be dependent for all their daily activities, and the level of support is very extensive. So this is what we find the mental retardation. Now the next PQR, which is 4 and 5, we can combine because they have the same symptomatology more or less. There is an expression of great anxiety and pain with a drawn condition and well-marked linea nasalis. Features are expressive of pain and anxiety. So it is a kind of a mental symptom, but then it is a behavior which is we have to observe. So what we have in this particular red line symptom, expression of great anxiety and pain. So we can learn to read the body language if you can see the expression and you are well versed in understanding the body language, which is more or less everybody knows about it. But then Well, magnesia lesionis from the point of view of anatomy and physiology and emotions is a very important facial expression which points to pain and suffering and side by side depression. Now, facial expression is an observational tool for assessing pain in children in a given clinical setting. So these particular two photographs will tell us that this particular child is having constant pain, ongoing pain, and there are not only magnesia nasalis, but then there are other muscles of expression. They are coming into the play. So the brows are uh, slightly pushed down anteriorly where we have uh, superciliary ridges are there, and there is lids are tightened, and the eye is closed, cheeks are raised, and we have nose wrinkled, means nasolabial fold is visible here. So it shows that the child is in pain or suffering, and there is a reactive emotion because of pain causes depression and anxiety both. Now we find sudden transient, there is a aggravation in terms of pain, whatever pain may be. If it is aggravated, so you will find intensification of these particular muscles of expression, facial expression. Now uh, brow is further has been lowered, and then we have lids are further tightened. Periorbital muscles जो periorbital muscles, ocular periorbital muscles have become much more tighter. Eye is firmly closed, cheek is further firmly raised, nose wrinkles we can see, lips are raised, upper lip is raised, and this mouth becomes open and jaw drops. So, and linear nasalis you can see is very prominent here. So these are the features which point towards the child's facial expression of pain, and this illustrates many of the core facial actions observed in the pain. So this is the reference from where this particular information is being taken. Now we go to the PQR6, herpetic eruption on the end of the nose. So we find that this is the febrile blisters, and these particular lesions they point to herpes simplex infection, and the clinical feature is that these particular lesions are because of herpes simplex virus HSV1, and it is acquired in early childhood from parents, relatives, through normal kissing, etc. And the first infection may be associated with mild to severe pain and difficulty in swallowing. Means it has got the throat infection, oral infection, which settles down more or less in due course of time, say for about 8 to 16 days, and the child becomes all right. But however, around 20% will have a recurrent infection. Outside the mouth, these are known as cold sores and most commonly seen on lips, around the nose and eyes. In the mouth, appear as a small painful ulcers on hard palate, gums, and at the top of the tongue at times. The PQR7 tells us that this child of Aethusa has complete absence of thirst. We have similar thirst, apis and pulsatilla, and it is reverse of arsenic. So it is a general characteristic where we have desire, thirst, and PQR9 we will take along with this indigestion of teeth in children. This is the next set of symptoms. Apart from milk intolerance, we have indigestion, where we find violent, sudden vomiting of a frothy milk white substance or yellow fluid followed by curdled milk and cheesy matter. So this is a characteristic particular general from the stomach, and we have to have the clinical correlation. There is a complete absence of thirst. This feature points to the characteristic uncommon symptom of this remedy. And indigestion of teething children, we have vomiting. But then please remember, vomiting is a disorder. It is not a simple symptom. It tells you that there is something terribly wrong with the child. In case of vomiting, the amount and content is more. It is not a passive but forceful action, and baby becomes cranky and depressed. He is in distress also. Baby needs medical attention. That is more important to understand at this moment. And then we have regurgitation. The milk regurgitation is functional in this age case. Rest of the children who doesn't have the milk intolerance, you will find the child is going to regurgitate the milk. Small amount of stomach content comes out slowly. Even after throwing curdled milk, baby is not in distress. That is the very important symptom we have to observe in the child. And the child who has suddenly had the big meal and he is not been burped up, you have to put it on the shoulder, and he should be able to allow the pass of gas. So if it is not done, the child will put down on the cot. He will definitely throw curdled milk, some small amount of curdled milk. The regurgitation is the next important reason of curdled milk coming out after the breastfeeding or after the having milk. This curdled milk, why it comes up? Because as the milk gets partially digested and is a mixture of milk, saliva and acid secretions. Please note that the curdled milk does not indicate any disease at this particular point. What are the predisposing causes for this normal kind of regurgitation? They include more in bottle-fed than breastfed child. Bottle-fed swallow more amount of air, and this is more common with overfeeding. Let us go to the PQR 7. Complete absence of thirst we have seen. Indigestion of the teething children we are dealing here with, and clinical correlation is continued. Diagnostic criteria for functional infant regurgitation, that includes the age of baby is less than 1 year. Regurgitation is more than twice a day, and duration is more than 3 weeks. The prognosis is condition is a self-limiting condition. It will settle down by the 1 year of age. What preventive measures we have to take? Avoid the bottle feed, especially before sleeping. Give small and big frequent feeds. Feed baby, especially in upright position. Hold the baby tight for upright for half an hour after feed. Soon after feed, help baby to burp. If the symptom persists beyond 1 year, you need further investigation and review of the case. There is a more frequent reflux, vomits large amount after 2 hours of feed. Vomitus is green or yellowish. Infant starts refusing feed. Infant is not gaining weight. These are the very important clues that this child requires further investigation to find the cause of regurgitation. Now the PQR 10 we have here is regurgitation of food an hour or so after eating, copious greenish vomiting. The most important symptom here is we are worried about here the greenish vomiting. This is a characteristic particular general symptom from the stomach, and something like this vomitus comes out. Clinical correlation being greenish vomiting points to vomiting of bile. It tells us that there is an intestinal obstruction unless proven otherwise. So we must take it as a medical emergency to start with, and the action on our part is to search for and review for other signs of obstruction if at all they are present, whether there is bloody diarrhea, abdominal distension, or in the baby is just born, you see that the perforated anus is present. So these are the things which you require to take into consideration. So let us revise about something. What are the common causes of intestinal obstruction in an infant? So volvulus related to malrotation of the midgut. This is potentially the most important and dangerous. Twisted bowel, which can cause the bowel to become ischemic, necrotic, and potentially perforate within a matter of hours. So the diagnosis and surgical referral for the treatment becomes urgent. Hirschsprung disease investigations which are going to help us in case of some serious problem. A supine abdominal X-ray will usually reveal an abnormal gas pattern, paucity of gas and distension of the stomach and proximal duodenum in the volvulus. More gaseous distension with lower obstructions and lateral decubitus X-ray will tell us about the fluid levels. Treatment in case of bowel obstruction. It is a medical emergency and surgical case needs urgent surgical referral and transfer to tertiary services with surgical capacity or capabilities. We have PQR 11, the epileptic spasms with clenched thumbs, red face, eyes turned downwards, pupils fixed and dilated, foam at the mouth, jaws locked, pulse small, hard, quick. It is a characteristic general which points to epilepsy, and clinical correlation is that above features classically points to grand mal epilepsy. The grand mal seizure has three stages. Stage 1 is the tonic phase. There is a scream at the beginning of seizure and there is a sudden muscle contractures causing person to fall down. Loss of consciousness occurs. This phase tends to last about 10 to 20 seconds, which is followed by the clonic phase. It is characterized by rhythmic contractions, alternately flexing and relaxing. Convulsions usually last 1 to 2 minutes or less, and during this phase, there is a loss of bowel and bladder incontinence, you can say. There can be tongue bite also, and it is followed by post-ictal phase. It is an altered state of consciousness which may last about 5 to 30 minutes after the convulsions are over. This is referred as post-ictal confusion, which has features like fatigue, sleepiness is common after a grand mal seizure. So let us recall the causes of infantile epilepsy. It is very important to illustrate in history perinatal hypoxia, hypoxic ischemic encephalopathy. Metabolic causes may be low level of glucose, calcium and magnesium in the blood. There can be infectious causes, say for example meningitis or encephalitis. The genetic cause Self-limiting familial infantile seizures could be there. So let us go to the PQR 12. Weakness and prostration with sleepiness after vomiting, after stool, after spasm. So clinical correlation is this is the weakness, prostration and sleepiness. It is a common symptom associated with following condition in a child like vomiting. After excessive vomiting, child can feel dizzy, weak and drowsy, especially if the person ends up dehydrated. In case of diarrheal stool, after stool, weakness and drowsiness comes rapidly due to losing minerals, sugar and water that the body requires. And in case of epilepsy, the post-ictal state is the altered state of consciousness after epileptic seizure. It usually lasts between 5 to 30 minutes, but sometimes longer in cases of larger or more severe seizures. And it is characterized by drowsiness, confusion, nausea, and other disorienting symptoms. Thanks. Thank you very much for patiently